Hello everyone, Assalamu alaikum. Today we will speak about the last part of the renal tumor. It is Wilms tumors and other pediatric renal tumors. As you see in this picture, this is patients operated for renal tumors with this large right renal tumors mass. Presentations. Wilms tumors is the most common primary malignant renal tumors in children, and the mean age of presentation is 3.5 to 4 years of old, and bilateral cross cases usually present earlier at mean age of 2.5 years of age. This is for bilateral disease. Wilms tumors is rare in newborn. A solid renal tumor in the newborn is more likely to be either congenital mesoblasthic nephroma or neuroblastoma. The most common presenting symptoms is an abdominal mass. This is for Wilms tumors, commonly present as abdominal mass, and the patient also clinically might have hypertension that occur in 65% of the cases. The microscopic hematuria may be seen, but the gross hematuria is rare. The physical examination often reveals large, smooth, firm flank mass, and this that's rarely cross the midline. This mass rarely cross the midline. Congenital anomalies occur within 15% of the patient's renal tumor in general, but the genitourinary anomalies of this 15%, including renal anomalies that's ectopia, ectopic kidney, or renal fusion like Horseshoe kidney or hypospadias with degree, and urethral duplication occur, hypospadias occur, and also cryptorchidism occur, and ambiguous genitalia. So this is a hypoplasia can occur. And this here, this is ectopic kidney with a patient with Wilms tumor, and as you see, this is the fusion of the kidney or Horseshoe kidney with a patient with Wilms tumor can be associated. This is the normal kidneys, and this is the agenesis, no kidney, and this is aplasia, that's it's become a very small or remnants of the renal tissue, and hypoplasia, this is the kidney become small compared with the normal one. So we have aplasia can associated with Wilms tumors, and this is ureteric duplication. This is a normal ureter, and here we have duplex kidney system, and here this is incomplete duplication, and this is blind ureter, and also we have inverted Y-X duplication. This here, a duplication associated with Wilms tumors, and hypospadias with first degree, second degree, third degree. And as you see, this is in generally speaks that the first degree occur in the glans and coronal. In glans and coronal, this is the first degree, and the second degree occur in subcoronal or distal benign or mid shaft, as you see in this picture. This is second degree hypospadias, and also this proximal benign is considered as a second degree. The third degree, this is in scrotals and scrotals or perineal. This is considered as third degree. This is the hypospadias associated with Wilms tumor, and also undescended testes or cryptorchidism is associated, and also we have ambiguous genitalia is also associated with Wilms tumor. Anorrhea, this is 1% of the cases of out of 15% abnormal development of the iris of the eye. So it is isolated. Anorrhea is associated with chromosome 11 disorders, and up to 33% of the patients with anorrhea develop Wilms tumor. So of 33% of the patients with anorrhea develop Wilms tumor. So 33% of the patients with anorrhea develops Wilms tumors, and this is anorrhea. Anorrhea is a complete loss of iris and pupil. This is anorrhea in this patient, and as you see, this is here blue without corneal graft, and here we have this is green with corneal graft. As you see, this is the graft, the suture material here, and here we have brown with corneal graft. This is anorrhea. The hemihypertrophy, 3% of the cases out of 15% may be ipsilateral or contralateral to the tumors. So isolated hemihypertrophy, it's not accomplished by other congenital anomalies. It's associated with chromosome 11 disorders. This is a patient with Wilms tumor show the presence of hemihypertrophy. Gross renal vein invasion occur in up to 20% of the cases, and acquired von Willebrand disease occur in 5 to 10% of the cases, a bleeding disorder characterized by deficiency of platelet adhesion factors. So 5 to 10% of the patients have acquired von Willebrand disease. So the etiology, the Wilms tumors is thought to arise from abnormal persistence of the metanephric blastoma or metanephric blastema. That's the metanephric blastema is an embryological structure that contains the nephrogenic cells. The pre-malignant lesions and nephrogenic rest are focused on the abnormally persistent nephrogenic cells. This is another theory. And Wilms tumors and nephrogenic rest are indistinguishable histologically. So we will not able to differentiate between them by histopathology between nephrogenic rest and Wilms tumor. The only way to differentiate them is the following their clinical course. Most nephrogenic rest do not develop into Wilms tumor. So nevertheless, the patients with nephrogenic rest must be followed closely. So a nephroblastoma or blastomatosis, diffuse or multifocal nephrogenic rest. So Wilms tumors genes, the Wilms tumor 1 tumor suppressor gene on the chromosome 11b13. So inactivation of Wilms tumors 1 result in Wilms tumor. Wilms tumor 2 on chromosome 11b15, inactivation of Wilms tumor 2, this actually causes Wilms tumor. So we have these genes, and we have 16 Q loss of heterozygosity at this site result in Wilms tumors. Okay, this is the 3 important genes for Wilms tumors. We have Wilms tumor suppressor gene on chromosome 11b13. So inactivation of this gene 11b13 Wilms tumor gene, it will lead to Wilms tumors. And also we have Wilms tumor gene on 2 on chromosome 11b15. Inactivation of Wilms tumor 2 can lead to Wilms tumors, and 16 Q loss of heterozygosity at this site result in Wilms tumor 2. Location of metastasis. From the most to least, we have the Wilms tumors first to the lung, then hepatic, and other sites include bone and rarely the brain. So the most common is the lung, and the second is the liver, and the other sites include bone and rarely to the brain. Disease associated with Wilms tumors, we have Weger syndrome, that's Williams tumor aneurysm and genitourinary abnormalities, and mental retardation. This associated with Williams tumor is known as Weger syndrome. Okay, that's W for Wilms tumors, and A for aneurysm, and G for genitourinary, and A for abnormalities, and R for mental retardation, genitourinary abnormalities and mental retardations. Associated with Wilms tumor gene 1, up to 30% develop Wilms tumor. So up to 30% of the Weger syndrome have a Williams syndrome. 30% of the patient have Wilms tumors of those who have Weger syndrome. Dennis-Drash syndrome, this is Wilms tumors, intersex disorder, and glomerulopathy with proteinuria. This associated also as Weger with Wilms tumor gene 1 on chromosome, as I mentioned, on chromosome 11b13, on chromosome 11b13. Okay, this is known as Dennis-Drash syndrome, DDS. It's associated with Wilms tumor, intersex disorder, glomerulopathy with proteinuria. Beckwith-Whitman syndrome, multiple gross abnormality, which may include vesromegaly, gignatism, hemihypertrophy, omphalocele, and macroglossia. All this it's associated with Beckwith syndrome. It includes organomegaly or visceromegaly, gignatism, hemihypertrophy, omphalocele and macroglossia associated with Wilms tumor 2 gene. This is, we mentioned this gene. It is located on chromosome 11, B15. So inactivation of Wilms tumor gene 2, this leads to Wilms tumor. So that's why the Beckwith-Whitman syndrome associated with Wilms tumors in 5% of the cases. Mixed gonad dysgenesis is also associated, and trisomy 18 also associated, and Perelman syndrome is also associated, and congenital syndrome such as aniridia also associated. So bilateral Wilms tumors. Approximately 5% of the cases of patients present with bilateral, only 5%. So that's bilateral occur in only 5%. Bilateral cases usually present early at a mean age of 2.5 years. So the bilateral occur in 2.5 years than unilateral, which occur in up to 4 years. Nephrogenic rests are always present in bilateral Wilms tumor. Thus, the presence of nephrogenic rest should arise as a suspicion of bilateral Wilms tumor. Bilateral tumors are generally treated with a perioperative chemotherapy followed by renal sparing surgery. When nephrectomy is performed for unilateral Wilms tumors, the presence of ipsilateral nephrogenic rest or nephroblastoma increases the patient's risk of developing a metachronous Wilms tumors in the contralateral kidney. So the metachronous Wilms tumors might occur in contralateral kidney in the patients who underwent nephrectomy for unilateral Wilms tumors in the presence of ipsilateral nephrogenic rest, or the patients have presence of nephroblastoma. This increases the risk of developing metachronous Wilms tumor in contralateral kidney. Therefore, these patients are followed more frequently regardless of the histology and stage. The workup history and examinations, including search for aniridia, hemihypertrophy, hypospadias, cryptorchidism, ambiguous genitalia, and also we'll do blood pressure measurements, and we will do investigation that includes CBC with platelet and also BT, BBT, and bleeding time, blood urine nitrogen, serum creatinine, liver function test, serum calcium, urine analysis. All this must be done. And obtain urinary catecholamine if neuroblastoma is suspected. Platelet and bleeding time and prothrombin time and BTT, all these 4 parameters obtained because, as I mentioned, 5 to 10% of the patient develop acquired von Willebrand disease. It is bleeding disorder. So we will do the platelet, bleeding time, prothrombin, and BTT for patients who suspected have Wilms tumors to check the von Willebrand, which is actually occurring 5 to 10%. Abdominal ultrasound is often initial imaging study for the patient with Wilms tumors. It can visualize the liver as well as the tumor thrombus in the vena cava. Wilms tumors usually have heterogeneous echo textures. So this is a finding in ultrasound. CT scan may be obtained if the solid renal mass is suspected based on ultrasound. Chest X-ray to assess for pulmonary emits also is indicated. Bone scan if the patients have bone pain and elevated alkaline phosphatase or elevated serum calcium. So what to do? The initial exploratory surgery. After complete workup, the initial therapy for suspected Wilms tumors is usually surgical exploration. However, perioperative chemotherapy is indicated in certain circumstances. We see it later. In general, a transfer supraumbilical incision is made. So supraumbilical transfer is made. Peritoneal exploration is performed to rule out metastasis. Biopsy should be taken of suspicious lesions and resectability is determined. If the tumor is unresected, close and administrate chemotherapy. Palpate the renal veins for a tumor thrombus. With the perioperative CT or MRI show a normal contralateral kidney, explorations of the contralateral kidney is unnecessary. When preoperative imaging show an abnormal contralateral kidney, the entire contralateral kidney is exposed and inspected. Biopsy any suspicious lesions, a cleft or discoloration suggests that's a nephrogenic rest. If contralateral kidney was abnormal on perioperative imaging but appear grossly normal during surgery, intraoperative ultrasound may localize the lesion for biopsy. After inspections of the contralateral kidney, close the aorta fascia. If bilateral tumor is present, close the patient and treat accordingly. Inspection of retroperitoneal lymph nodes, biopsy abnormal nodes and obtain random nodal biopsy. Regional lymph node dissection does not improve survival but maybe provide prognostic information. If the treatment is unilateral, perform a nephrectomy and the tumor's thrombectomy if indicated. If the tumor resect the adrenal gland, if it's gross involved, the tumor is in the upper bowl of the kidney or the adrenal is adhered to the gland. So if the tumor involved in the adrenal gland, grossly, we will do a resection for adrenal gland, or if the tumor in the upper bowl of the kidney, also we will do resection for the adrenal gland, or if the adrenal adherent to the kidney, also we will remove the adrenal with. So preoperative chemotherapy has not improved survival, but may reduce the morbidity of the surgery by shrinking the tumor. So it is administered when the mass has any of the following characters. So we will use chemotherapy in the following: unresected at the initial presentation or bilateral renal involvement, or the patient have extensive intracaval involvement. So those group we will prefer to do for them chemotherapy. We have a stage of the Wilms tumor. Stage 1 tumor confined to the kidney and completely excised as a margin negative, no capsular presentation, no tumor split. So this is stage 1. Or no nodal or hematogenous metastasis. If no nodal or hematogenous, this is stage 1, that the tumor confined to the kidney and completely excised as a negative margin, no capsular presentation, or no tumor split, no lymph nodes, or no lymphatic or hematogenous spread. Stage 2, that's local extension of the tumor outside the kidney and completely excised. We have extension outside the kidney, but it's completely excised. The invasion in perinephric tissue or presence of the thrombus into the renal vein or vena cava, margin negative, tumor thrombus completely removed. All this include in stage 2. A non-nodal or hematogenous metastasis is considered as stage 2. But the main point is that the tumor local extension of the tumor outside the kidney. Here we have the tumor in stage 1 that's located to the kidney and completely excised. Here it is invade the perinephric tissue or presence of the thrombus in vena cava or renal vein, and the margin negative as well as stage 1, and non-nodal or hematogenous spread. Stage 3, that's incompletely resected intra-abdominal mass. Incompletely resected intra-abdominal mass, tumor split and positive margin. This is considered as stage 3, but they have no hematogenous intra-abdominal spreads. That means positive regional lymph nodes and peritoneal invasions or peritoneal implant. All this considered as non-hematogenous intraperitoneal spread. So intraperitoneal spread non-hematogenous is stage 3, which incomplete resected intra-abdominal tumor split with positive margins, or tumor was a biopsy before excisions, or no non-regular nodals or hematogenous metastasis. So that we have just peritoneal metastasis. This includes stage 3. Stage 4, that's metastasis, it is hematogenous or non-regional nodal metastasis. This is stage 4. So it is hematogenous spread, that is stage 4, or non-regional nodal metastasis. Stage 5, that the tumor is bilateral. If the tumor bilateral diagnosis is considered as stage 5, an attempt should be made to stage each side by above criteria before the biopsy. Pathology and histology. Gross features. Tan tumors with pseudocapsule cyst may be present. Microscopic feature, 3 tissue elements must be present, that is stroma or epithelial cell or blastema. The blastema and stroma and epithelial cells, this is a microscopic feature of Wilms tumors. But the gross features is that the tumor have a pseudocapsule. And cyst might be present, but mainly pseudocapsule. Histology, favoral histology is most common. That the favoral is most common. Unfavorable histology, anaplastic histology, only in 5% of the cases. Nuclear enlargement that's more than 3-fold larger than adjacent cells. Nuclear hyperchromasia that's present, or abnormal mitosis. This is the unfavorable histology. If we find this it's actually occurring in 5% of the cases, with nuclear enlargement that more than 3-fold larger than adjacent cells, nuclear hyperchromasia and abnormal mitosis. This histology is rare when Wilms tumor is diagnosed at less than 2 years. So if we diagnose a patient in lucky patient less than 2 years, we will find that there is no unfavorable histology. Unfavorable histology has shown worse prognosis. Clear cell sarcoma and rhabdoid tumors are no longer classified as unfavorable histology Wilms tumors. They can classified as non-Wilms tumor, so it is classified separately. Favorable histology, it is occurred in 95% of the cases and no characteristic of unfavorable histology. Wilms tumor follow-up, initially obtain follow-up test at least every 3 months. Histology and history and physical examinations, that especially abdominal examination. Serum, we will do blood urea, nitrogen, creatinine, liver function test, and urine. All this occur in the first 3 months, every 3 months. Every 3 months, we will do history examination and routine investigation, blood urea, nitrogen, creatinine, liver function test, urine. Abdominal ultrasound every 3 months. If for any stage with this unfavorable histology, or stage 3 to 4 with favorable histology, or any stage with nephrogenic rest, or patients have favorable histology, stage 1, 2 without nephrogenic rest may be imaged less often. So this is the patients who might need ultrasound every 3 months for any stage with unfavorable histology, stage 3 to 4 with favorable histology, and any stage with nephrogenic rest or favorable histology for stage 1 and 2 without nephrogenic rest may be imaged. And also we will do chest X-ray every 3 months. So all it is every 3 months, we will check by abdominal ultrasound and chest X-ray for the patient suspected have pulmonary bleeds. When the nephrogenic is performed, the nephrectomy is performed for unilateral Wilms tumors, the presence of the bilateral nephrogenic rest or nephroblastoma increase in the patients who are developing metachronous Wilms tumors in contralateral kidney. We speak about this. Therefore, these patients are followed by more frequently regardless of the history and stage. If metastases were present, the metastatic location should be monitored with routine imaging. In patients receiving radiation to bone, image studies of this patient area should be conducted at least each year until the bone growth is complete, and also then the at least 5 years thereafter. So this is patient receiving radiation for bone, and the image suggests that the area should be conducted at least each year until bone growth is complete. Secondary malignancies such as osteosarcoma have been reported after radiation in Wilms tumors. Side effects of doxorubicin include 4 to 17% long-term congestive heart failure. So the congestive heart failure occurring to 4 to 17% of the patients. Consider monitoring the patients for heart disease. Most recurrent occur within 2 years of the diagnosis. Therefore, follow-up should be intensive during this interval and may be less frequent thereafter. Patients with solitary kidney should be advised that the participations in contact or collisions sports leave the kidney at the risk for traumatic injury. Need to avoid contact collision sport is determined on individual basis. Relapse. The lung is the most common site of relapse. Relapse usually occurs within 2 years of the diagnosis. Treatment of the relapse often consists of the combination of surgery, radiation, and chemotherapy. Patients have not had doxorubicin, that means the patients who have not had chemotherapy or who have had a chemotherapy without doxorubicin are given doxorubicin-based chemotherapy. There is no consensus regarding chemotherapy regimens for patients that relapse after receiving doxorubicin. Factors that increase risk of relapse: age of 2 years, higher stage, and unfavorable histology. Histology is the most important prognostic factors. Lymph node metastasis or hematogenous metastasis. This factor increase the risk of the relapse. No apparent influence on the survival, the level of the caval involvement or lymph node dissection. These have no apparent influence on survival. Factors that increase the local recurrence: unfavorable histology, tumor split, and also positive surgical margin, incomplete tumor resection, lymph nodes metastasis, or other pediatric malignancies. So, a relative frequency of malignant pediatric renal tumor. We'll speak about the other malignant pediatric tumors. The other malignant pediatric tumor, we have relative frequency of malignant pediatric renal tumors. We have Wilms favorable histology is 89%, and we have Wilms unfavorable histology 5%, and we have rhabdoid tumors, this is 4%, and clear cell sarcoma, this is 2%. We'll speak about the clear cell sarcoma. This tumor is not classified as Wilms tumor. It is rare sarcoma. Clear cell sarcoma often of the kidney. The mean age of this diagnosis as 3 to 4 years of age. And this tumor has been called a bone metastasizing renal tumor of children. It's called like this, bone metastasizing renal tumors of children. This is known as sarcoma or clear cell sarcoma. Okay, this clear cell sarcoma of the kidney is known as tumor bone metastasizing the renal tumor of the kidney because bone is the most common site of metastasis. 50% of the patient present with bone metastasis. If this patient is discovered, a bone scan must be performed. This tumor has worse prognosis than Wilms tumors. The treatment for this nephrectomy followed by chemotherapy and external beam radiation for bone. In non-Wilms tumors, the chemotherapy regimens consist of doxorubicin, vincristine, actinomycin, cyclophosphamide, and etoposide. This is the 5 chemotherapy for non-Wilms tumors. The 4 years relapse-free and overall survival with treatment is 65% and 75% respectively. This is the 4 years survival. 4 years relapse-free survival or an overall survival. This is the 4 years relapse is 65% and overall survival with treatment is 75%. Rhabdoid tumor of the kidney. This tumor is not classified as Wilms tumors, and it is also rare sarcoma. Is known as rhabdoid tumor of the kidney. Mean age of this 13 months. 13 months. The most common metastatic site is the brain. Rhabdoid is the most common metastatic is the brain. All patients that have this tumor should be undergo brain CT or MRI. Rhabdoid tumor has the worst prognosis of all children renal masses. Treatment is nephrectomy followed by chemotherapy and external beam radiation. In non-Wilms tumor 5, the chemotherapy regimens consist of carboplatins, etoposide, and cyclophosphamide. This is the chemotherapy for rhabdoid non-Wilms tumors. Okay, carboplatin and etoposide and cyclophosphamide, compare with chemotherapy for clear cell sarcoma. Clear cell sarcoma, as you see, that doxorubicin, vincristine, and actinomycin, and cyclophosphamide, and etoposide, this is a 5 chemotherapy for them. But the rhabdoid tumor of the kidney have this carboplatin and etoposide and cyclophosphamide. And overall, the 4-year relapse-free rate is 25%, and overall survival treatment 26% respectively, compared with those for clear cell, which is 65%, and for relapse-free and also overall survival is 75%. This is here for a patient with, this is a 4-year relapse-free rate, 65%, and overall survival 75% for patient with clear cell sarcoma. This is a treatment, as you see, as we discuss it all in details. The favorable histology stage 1, stage 2, stage 3, and 4. Stage 1, but it is less than 1 year, we'll do surveillance. And if more than 2 years, sorry, less than 2 years, we'll do surveillance. That's if the tumor more than 2 years, or the tumor, it's about 550 grams, 2-agent chemotherapy, VA, that's is abbreviated vincristine and actinomycin D. This is stage 3-4, 3-agent chemotherapy, that's doxorubicin and vincristine, and also actinomycin. This is for stage 3 to 4. If this is a favorable histology. Unfavorable histology is stage 2 to 4 or stage 1. Stage 1, we will do 2 agents, unfavorable histology, chemotherapy, that's vincristine and actinomycin D. If unfavorable histology, that's stage 2 to 4, it is focal anaplasia or diffuse anaplasia. Focal anaplasia, we will use 3-agent chemotherapy, that's doxorubicin and vincristine and also actinomycin. And it is diffusible anaplasia, diffuse anaplasia, we use 5 agents. 5 agents, it's used for diffuse anaplasia, that's plus external beam radiation. Okay, this is 5 agent, doxorubicin, vincristine, and actinomycin, plus cyclophosphamide and etoposide. This is for the management of the survival rates. Tumor, Wilms tumors, stage 1 survival rate for 4-year survival rate, free survival rate, it is 92, but it's 4 years overall survival 98%. Stage 2, it is 85% in 4-year survival, free survival, and 96% overall. Stage 4, that's 3, that's 90% 4-year survival, free survival. Stage 3 is 95% 4-year survival overall. And stage 4, it is 80% free survival, and it is 90% overall survival. Stage 5, it is 65% free survival, and overall it is 56 to 87%. That survival is better on those with negative lymph nodes and favorable histology, or younger age group and lower tumor stage of each kidney. This is for stage 4. And we have the unfavorable histology, any stage, that's the survival is 60%, and in both 60% and 66% in overall. This is free survival 60%. So if it's clear cell, that's any stage, it is 65% in 4-year survival and 75% overall. So if the patient have a rhabdoid sarcoma, that's any stage and any histology, it's actually 25% for free survival, and it's overall it is 26%, as we mentioned it previously. And this is a stage of Wilms tumor from 1 to 5 with favorable histology. All this is this survival, as we discussed it. We come to multicystic nephroma. Multicystic nephroma is a benign cystic renal mass presentation. It's virtually always unilateral. Incidence is highest in two population, male children, and usually age less than 2, present with paleness abdominal mass. Female adult, usually more than 40, present with pain and hematuria. This is multicystic nephroma. It is benign renal cyst. The multicystic nephroma pathology, it's microscopic. That's gross, circumscribed non-classified mass with fibrous capsule surrounding the non-communicating cyst. This is a macroscopic. The microscopic cyst separated by fibrous septa. Note the imaging cannot differentiate between the multilocular cystic nephroma and malignant cystic masses, the cystic films. This is the image. So renal scan usually show that the affected kidney does function. Multilocular cystic nephroma treatment, nephrectomy is curative in these patients. If nephrospastic surgery is performed, consider intraoperative frozen section to rule out malignancy. Mesoblastic nephroma. Mesoblastic nephroma is the most common solid renal mass in the newborn. This is mesoblastic nephroma. It is considered benign, but it may be locally invasive. Metastases are rare and usually associated with cellular variant. The presentation mean age group is 3.5 months, and it's uncommon of age of after 6 months. So it usually occur under 6 months. In the mean age group of 3.5 months, it is more common in male, usually discovered as unilateral abdominal mass associated with polyhydramnios in utero, and 14% of the patients have associated congenital anomalies. Mesoblastic nephroma, the congenital mesoblastic nephroma have a macroscopic, we mentioned that gross resemble as leiomyoma, and it is fair rubbery-like colors. It is integrated with surrounding kidney. There is no capsule, and classification are absent. This tumor may be friable and prone to ruptures. The microscopics, we have spindles that infiltrate the renal parenchyma. As you see, this is a spindle infiltrate the renal parenchyma, and here we have entrapped of islands of renal parenchyma. This is the neonatal glomerulus. Okay, so we have syn wall, vascular space, and a spindle with a fascicular architecture and low mitotic activity. So a spindle that's infiltrate the renal parenchyma, classical variant, rare mitotic figures, and also we have cellular variants that's densely cellular mass with many mitotic figures. Now the image cannot really differentiate this mass from other solid renal mass. So the histology is diagnostic. Mesoblastic nephroma treatment, nephrectomy with wide local excision is usually curative. Complete resection and avoiding the tumor split as imperative to prevent the local recurrence. So there is recurrence in local area. Patient diagnosed at the age less than 3 months of age and may have lower recurrence rates. So also local recurrence is uncommon. It does occur. Therefore, surveillance after nephrectomy is recommended. Multicystic dysplastic kidney, or MCDK, that is a congenital benign cystic dysplasia of the kidney, presentation usually as a childhood abdominal mass found incidentally on perinatal ultrasound. Multicystic disease of the kidney is associated with contralateral vesicular reflex, VUR, in 20 to 40% of the cases, and contralateral uretropelvic junction, that obstruction in 3 to 12% of the cases. So vesicular reflux that occurs is the most common defect associated with MCDK. Therefore, patients with MCDK should be done under voiding cystourethrogram. We will do this because reflex possibility in patients with multicystic dysplastic kidney. This is a normal urinary system with kidneys, and this is a multicystic dysplastic kidney in this case here. Pathology of multicystic dysplastic kidney, it is actually macroscopic gross appearance cyst with minimal renal parenchyma. It's known as a bunch or grapes, bunch of grapes. As you see here, this is a bunch of grapes sign in patient with MCDK, and it is actually the ureter is usually a atretic. Okay, so the microscopic histological appearance primitive tubules that are not organized into nephron is known as disorganized architecture. So ectopic cartilage is often present in patients with MCDK. So we will find the cartilage, and it is have this clinical finding in imaging is known as bunch of grapes. Bunch of grapes, as you see, this is after nephrectomy. Imaging ultrasound show non-communicating cyst and minimal parenchyma. Small communicating may exist, but they are not visible on ultrasound. Where hydronephrosis, usually fluid-filled area that have visible communication. Renal scan usually shows that the affected kidney does not function. Sometimes MCDKs involve into numbness or disappear completely. So can develop in up to 8% of the cases with MCDK. That's the numbness or disappear completely. This is the not functions. MCDK treatment, patient with UPJ obstructions or uretropelvic junction obstructions, and VOR should be treated accordingly. Patients with MCDK should be observed with ear blood pressure measurements. A repeat renal ultrasound can be performed at 1 year of age, and perhaps another ultrasound at age of 6 years. So if the kidney enlarge or becomes symptomatic, the patient might develop hypertension, nephrectomy should be performed. This is the difference cystic renal mass. As you see, this ultrasound shows gross visible communication between fluids, space, or functional kidney on the renal scan. MCDK, it is not appear grossly in ultrasound, and also not functioning kidney on the renal scan. That's not appear. And multilocular cystic nephroma that have no appearance on ultrasound, and also it is actually have a function on the renal scan. Cystic Wilms tumors, this is a not appearing ultrasound. That's a grossly visible communication between fluid space, no on ultrasound, as well as MCDK or MLCN. But actually, it is appear function on the functioning on the kidney, functioning kidney on the renal scan. Hydronephrosis, it's on ultrasound. You will find it very clear. That's gross visible communication between fluid space, but the function on the renal scan, sometimes it's appear in patient with hydronephrosis. Survival for pediatric renal tumors. This is a tumor and 2 years relapse-free survival, all stage combined. Multi-ocular cystic nephroma, 100%. Mesoplastic nephroma, 98%. Wilms tumors is 84%. Clear cell sarcoma is 75%. Wilms tumors, and that's the Wilms tumors here with favorable histology, here with unfavorable histology, 63%. And rhabdoid sarcoma is 25%. This is the end of the lecture. Thank you very much.